Thank you, Margaret and Vicky. It's a pleasure to be here, and I thank the ICRS for inviting me to talk on this subject. I do have financial interest to disclose on both the laser technology that we use with these combined techniques and the cross-linking devices. It was at this meeting in Academy 08 that we introduced higher fluence cross-linking, and also at the ICRS several years ago that we introduced different attempts to perform cross-linking. And it is really unfortunate that cross-linking in the US is still not just off-label, it's not FDA approved at all. This is a procedure that, as you saw from all the talks, is globally an effective means not only in stabilizing ectasia, but also modulating biomechanical behavior of the cornea. And in combining laser and cross-linking, we use cross-linking after LASIK procedures. We introduced this technique as well in treating eyes that were in high risk for ectasia, younger patients, high myopic results. And we did present, this is published at the insert of the Journal of Refractive Surgery, that when combining cross-linking and LASIK in hyperopia, you get a favorable long-term stability effect. So I'm convinced, this is a contralateral eye study that we're publishing this month, that for hyperopes, cross-linking is the key manipulator of biomechanical response to keep those results long-term stable. Now, going into manipulating cornea regularity, we have shown several years ago that here an eye that is cross-linked and the cornea is stabilized and has flattened some, but a lot of these corneas are extremely irregular, and visual acuity does not really measure the way that patient drives, reads, and function in everyday life. If you study topometric data on these maps, they're terrible. The quality of vision is terrible, and a lot of these patients do remain, if they cannot wear contact lenses, with a significant visual rehabilitation problem. So we spoke, and it was in this meeting again several years ago, about 8 years ago, of the ability of using topography-guided modulation of the cornea surface and normalizing these corneas. Now, I'd like to draw the line for the US colleagues that this is not PRK. This is not having a keratoconic patient that we're treating 2 diopters of myopia, by no means. This is a very irregular treatment, and I'll elaborate a little bit more on this, although there's significant literature and some from our group on this technique. We use different modes to insert topographic data, and I currently use the Alcon Wavelight platform, which allows for 4 different topographic and topometric devices to enter data. And this is a treatment plan, as you can see here, which is, for instance, as far as a Pentacam, you're able, on the laser, to design the treatment. And this treatment is a very bizarre treatment. It's part hyperopic, as you can see here, and part myopic. Now, why would you want to do a hyperopic treatment or part hyperopic treatment in a usually myopic eye? The key thing here, and this is key to our technique, is you'd like to elevate this part of the cornea and thus normalize the central part of the cornea and improve the topometric indices for that eye and thus visual function. Now, another key element in the treatment is using PTK prior to the topography-guided partial PRK, 50 microns, 6.5 millimeters. So this is the procedure PTK, topo-guided partial PRK. We only treat 30, 40 microns at the time. And although I know it sounds extremely bizarre, according to what we heard today, removing tissue on a cornea that's already thin, it is a negative. I'll speak a little bit about the positive things that come in with this intervention. Mitomycin C and then cross-linking, high fluence cross-linking. Currently use the Avidra device, 10 milliwatts for 10 minutes. So in quick review, this is the PTK and then topography-guided PRK. As you can see here, these are very small treatments in thickness, 10 to 50 microns, mitomycin C. Our population in Southern Europe tends to scar a lot after surface ablations, riboflavin solution, and then directly collagen cross-linking without a soaking interval, because with Bowman's being removed, riboflavin soaks readily within the cornea. So we did report several years ago a comparison of doing first cross-linking and then maybe in the future laser and doing both at the same time. And it appears that doing both at the same time is dramatically synergistic. The results in visual acuity, visual function, and flattening of the corneas, very impressive. I'll take you to some severe keratoconic eyes. As a cornea surgeon, up until 10 years ago, this eye would have a cornea transplant. So this cornea would be in the histology lab of the hospital. So this is a very regular cornea. After the treatment, a lot of the indices, and I will suggest we evaluate the IHD as the key index of height decentration, as the key index of visual function and improvement with this technique. So improvement of the IHD almost halved. Obviously, this patient still needs a significant correction. This is again another patient before and after, and you can see here the topometric device thinks that this patient has keratoconus, although we can see the cornea is irregular and started from a stage 2 to 3. This is another pre and post, and you can see the regular treatment and the change. So you can see here how effective this treatment is to the change is identical to what we had planned, and I think this is a very high index of efficiency with these treatments. And again, just to prove the point, this is not a refractive procedure. This patient starts almost plano, plus 0.75, minus 3.5 diopters of astigmatism, and ends up myopic, but with improved indices and thus better visual function. So we found that some of the eyes had improvement in uncorrected visual acuity, but all of the eyes had dramatic improvement in best spectacle corrected visual acuity. As far as safety, we had no eyes that lost visual acuity. This is interesting. Going long term, 2 and 3 years, you can see there's a progressive flattening, so one has to underscore the refractive part of this correction, because the corneas will flatten further in the future, and thus you do not want to overtreat. We reported last year at this meeting that there is some cost to this procedure. There's some delayed epithelial closure, and these eyes need a little bit more babysitting than your usual cross-linking cases. This is a common finding, which in my opinion shows some difficulty in limbal stem cell feeding epithelial cells in the surface. And an interesting study I'd like to share with you, a friend from Cairo, Egypt, that had worked with us on the Athens Protocol is running a study where he's comparing keratoconic patients, one eye, the Athens Protocol, topo-guided PRK and cross-linking, the other eye, intracornea rings and cross-linking, and he has found a dramatic skew in the Athens Protocol eyes as far as best corrected visual acuity, quality of vision, and less glare, although those eyes have a longer recovery period compared to the intacts. And just closing, and I'd like, especially for the U.S. colleagues, to understand that collagen cross-linking may be a very, very vigorous manipulating factor in cornea response, and we're introducing in this meeting the use of flash collagen cross-linking in astigmatic keratotomies, and being able to reduce the arc that we need with current nomograms for astigmatic keratotomies in half. And this is a case, this should read 1 month, and you can see how wide the epithelial plug in this patient, because this AK was cross-linked and thus was more effective. So in conclusion, this is not a refractive procedure. It's very predictable in improving best spectacle corrected visual acuity, although not very predictable in eliminating refractive error, and it has a synergistic effect with collagen cross-linking, and these are our current protocols in Athens. I invite you to attend the cross-linking spotlight session of the Academy, and I thank you very much for your attention.